sort of touched upon the limited role of radiation for primary lesions. But what about some in the adjuvant setting for nodal disease?
Yes, so it's so we know that melanoma does travel to lymph nodes, and patients with a higher risk melanoma may commonly have a sentinel node procedure to see whether there is disease. And we actually have had a randomized trial, and kudos to the Australians for performing this, because they took patients with high risk melanomas, and this typically involved nodal disease, and it was a bit of a complex stratification, or the patients who were treated with radiation were treated on a bit of a complicated criteria set, which involved the number of lymph nodes and the location and the size and whether the cancer had spread outside of the lining of the lymph node. But they flipped a coin to say radiation or no radiation to the nodal basin, or the area where the lymph node was located. And this was a positive trial in the sense that the radiation did what it was supposed to do. It reduced the local recurrence rate of melanoma in that area. And it did so by about 50%. So if you look at the groups, and they have 5-year follow-up reported, twice as many patients had recurrences in the lymph node area who did not have radiation, who just had surgery, as opposed to those who were also treated with radiation. Now, what was not observed in this study was an improvement in overall survival statistics.
Sure.
So we did not establish that this helped patients to live longer or more patients to be cured of melanoma with this intervention, even though it did improve local recurrence. But there could be many reasons for this. Perhaps the study wasn't large enough to detect that survival difference. Perhaps if we had another study that had different criteria, we would see this. So we're in a circumstance where when a patient does have a lymph node metastasis of melanoma, we have to decide, I think, on an individual basis as to whether to deliver radiation. And also, we have to consider what other therapies the patient may be having. So, for example, the study that I referred to, the TROG study, or the Australian study, it was begun at a time when immunotherapy was not very prevalent. And so what we discuss in our meetings and academically is, well, how can we interpret this or apply this in an era where immunotherapy is commonly used? And it could go, you could argue either ways. You could argue that immunotherapy is better at controlling distant disease, so local control should be more important, and maybe the study would be positive for overall survival benefit. But you could also argue the opposite side, which is that immunotherapy would clear the local component, and perhaps the radiation would not have as much of an effect. And so it's an interesting debate that we may have for each individual patient. But I think the proof of principle, at least, has been established, which is that radiation should help with local control for patients. And then the question becomes, is that going to be worth it? Or does that make sense in the setting of any individual patient's case?
Yeah, especially in the setting of, we have all this immunotherapy at this point, right?
Exactly.
Yeah, and I think that is a debate that it's still a kind of a controversy like you're talking about. But coming back to that trial, did all these patients just have a positive lymph node biopsy, or did most of them also have a dissection?
It varied. So I would have to look back at the trial to see the exact numbers, because it was done as surgical practices have changed from doing full axillary dissections in the setting of any positive lymph node to just doing sentinel biopsy. Sometimes not even doing a sentinel node, biopsy. So So I'm not sure exactly the numbers for
And
each.
and another question I have is, does the adjuvant radiation create other added complications such as lymphedema, or is that added risk in that group of patient, or compared to the group that hasn't been treated, that was the same?
Sure, yeah, that's a good question. And in the study, the most common side effect that was associated with radiation is a skin reaction.
Sure.
And so when we give radiation, you commonly get an irritation of the skin. The skin turns red. In some cases, it may heal and become a full kind of sunburny sort of reaction. This tends to be a temporary side effect and tends to go away within about 2 weeks after the radiation is over. But in addition to that, they did notice that for patients who were treated to sites that would affect the lower limb, they didn't actually report that there was a higher incidence of clinically significant lymphedema, but they were careful in this. They actually measured the limb size of patients for both arms. And the patients who had radiation did have slightly larger limb size for lower extremity, or for sites affecting the lower extremities, not for the upper extremity.
So that means they're more affected on the leg, not the arms, basically.
Exactly.
Okay. I just want for clarification. Okay, go ahead. Keep going.
Right. So I think a careful observer might notice that there was some lymphedema, but is it a clinically significant lymphedema? It wasn't really considered that per se, but we do have to consider that as
And another question usually is, how long did the study follow these patients? Because I think usually, is it just 1 year out or like 5 year out? Because obviously will that change?
Right. So the first report of the positive study was without long-term follow-up. And so they commented that they could not really make judgments, but they have published a follow-up on this paper. And I've seen their 5-year follow-up reported, and that's when they reported on limb size.
Got
and that as a late effect of radiation. And the benefit was maintained over those 5 years. So with long-term follow-up, there was still about a 50% relative risk reduction in local recurrence.
Got it. Got it. So another question to follow up, and we sort of touched upon a little bit. I think it's something very important to mention. Is it correct to think that the lymphedema issues usually are worse when you radiate the groin area versus the head and neck versus axilla?
Yes, I think that's my own personal clinical observation, but also I think borne out in that randomized trial. The groin area is more vulnerable to developing significant lymphedema.
What are other risk factors that will, predispose someone to have more risk of lymphedema?
Typically, it's perhaps in someone who's more obese and maybe more sedentary. So a fit and athletic patient would be at less risk for developing lymphedema. But I don't believe that was specifically stratified in the TROG trial.
Okay, shifting gears.